Welcome to week 10 and our final week of the quarter. As I mentioned at the beginning, we will have covered a vast majority of the DSM. However, we're not going to cover all of the issues that are contained there. Not included in this class are going to be the neurocognitive disorders. There just is not enough time, and those conditions require additional testing and assessment to determine their presence over and above what can be assessed through the mental status exam. So, with that stated, let's delve into our final groupings of diagnoses, and those are going to be the neurodevelopmental disorders and autism spectrum disorders in this particular module. These disorders comprise the issues that are generally first noticed during childhood. However, this category of conditions can also manifest in adulthood or be present in adulthood. However, their presence will first be noted in childhood. So I hope that's clear. These are disorders that we can diagnose in adults. However, they must have first presented during early developmental periods. In this way, they are not considered childhood disorders as they were once considered in previous iterations of the DSM-5. As you can see here, the neurodevelopmental disorders include your communication disorders, your intellectual disabilities, motor disorders, autism spectrum disorders, attention deficit hyperactivity disorders, and then your specific learning disorders, those things like a learning disability for math or learning disability for written expression. Now, while this categorization entails many issues, our review of them is going to be somewhat brief, as understanding them is a little bit easier and less complex compared to some of the other conditions, but we're going to go through them nonetheless. What is meant by the term neurodevelopmental? It is meant to describe an early manifestation of symptoms, meaning they appear during those early developmental periods. Now, while childhood is a chaotic mix of behaviors in children, there is an expectation that children will still be able to understand some of the social expectations to be followed, at least according to a developmental expectation time frame. Most adults expect a level of compliance and body control and management by school entrance time. So this is often the time that we look to see things coming together in terms of language, behavior, those sort of things. For many, for many children, this is going to be when those neurodevelopmental issues become more obvious. So a parent without the benefit of developmental comparison, meaning they only have a single child, they may not recognize that their child's behavior does not fall in line with expectation. School administrators and teachers, they're going to have a wider and hopefully well-trained a wider awareness of what falls inside of neurotypical behavior and what represents neurodivergent behavior. So it's going to be at this time that the issues, that school age, it's going to be the time where those issues start to surface and become more obvious. In the case of neurodevelopmental issues, they can occur or can co-occur, meaning that a person can have more than one of the conditions in this particular category. So if you see a person that has an attention deficit hyperactivity disorder, in addition to an autism spectrum disorder that wouldn't be unusual. Let's start our discussion here on the communication disorders. Now, the communication disorders are going to present in three general areas of expression. The deficits will come in that way. So the deficit might come via usage, which is the ability to use language, whether the language is being used in a spoken way, written, signed, or even through the use of pictures. Sound is going to be another communication area. We're not talking here about hearing capacity, instead, the ability to articulate appropriate sounds in language. And then when we're talking about fluency, it's the awareness of the nuance in language. When we speak, sometimes we speak literally, right? But there are other times when there is non-literal language. So the ability to understand that nuance, whether it comes through verbal means or nonverbal, by way of expression, attitude, and actions. With that understanding of the communication disorders coming by way of sound and usage and nuance, we have different types of disorders. We have language disorder, speech sound disorder, childhood onset fluency disorder, which is stuttering. We also have social communication disorder, which is pragmatic in nature, social pragmatic communication disorder. And then we have the unspecified communication disorder. With language disorder, there is a deficit in understanding and comprehending language that makes learning and using language more difficult. Importantly here, language is not, again, just referencing spoken language, but written, signed, and the understanding that comes through pictorial representation. Because of this deficit, the vocabulary then also becomes limited. When a person's vocabulary is limited, this means that their ability to form sentences and concepts also becomes reduced, which means that language used as a tool to communicate then also becomes greatly impacted. Hence, the communication disorder by way of language acquisition. We recognize how this means then that understanding and being understanding become linked. I'm having a difficult time acquiring language and then using it. So now my ability to exchange with another person becomes understood, not just in the sharing, but in the receiving understanding of language as well. When children are assessed by pediatricians or developmental providers, okay, whether that's pediatric or a psychologist, they have this understanding. They're driven by an understanding of what children should be capable of at various ages, like the number of words they should have by a certain age, the number of words they should be able to properly use, and those sort of things. So the comparisons that we're making in a language disorder come based on those expectations of learning and then expression of that learning. It is from these norms that language acquisition is assessed and then a disorder is rendered. What do I mean by that? If you don't have a grasp of that understanding, your ability to give a language disorder is going to be impaired. You should not be rendering this disorder without those developmental anchors to lean into, which means you may pair with someone who has the ability to make this particular diagnosis, but you wouldn't make it without that additional understanding and training. Our speech and sound disorder is sort of as the name suggests. It's not associated with acquiring and comprehending language like happens with a language disorder, but it is describing the difficulties with sound production. In this way, it focuses on articulation, fluency, and then vocal quality. As with the case with language disorder, it's not that the case that a person has to meet a certain number of symptom criteria. Instead, to meet qualification, there is difficulty in all of these areas here on the slide. There is a difficulty in producing sound in speech, and as a result, effective communication is limited, along with social participation. The deficit has impact on the person's ability to learn and to be taught. It also interferes with occupational performance. As noted, the onset of the issue occurs during early developmental periods. As with the other disorders in the DSM, there's a need to rule out other issues prior to settling on this particular disorder. Because there are various reasons that could create an inability to produce sound, those must be considered here before the disorder can be given. So things like hearing loss, cleft palate, right? Cerebral palsy, those things have to be ruled out before this condition can be given, because if a person has an issue with their palate, then the ability to produce speech via sound will automatically be impacted. And we are going to go with those issues as the reason for this speech and sound disorder. So I hope that part is clear. In the DSM, stuttering is referred to formally as a fluency disorder. It involves yet another aspect of communication difficulty. It represents, of course, we understand this, that pattern of speech that doesn't meet developmental expectation or an expected skill set. Instead, it's speech that is halting or where there is stammering with broken words or syllable repetition. That's not a function of a hearing deficit or any sort of neurological issue or problem. As a function of having the stuttering manner of speech, anxiety can be created with social and performance impacts. So we know that we have social anxiety disorder, we have avoidant personality disorder, and those sort of things. In this instance, the angst that comes and the performance impacts are specific to this fluency or stuttering issue. If that's the case, you are going to give a fluency disorder if the reason for the social isolation has to do with the person's difficulty in producing speech that flows without stammering. If, going back to social anxiety disorder, the reason for the social avoidance is the person's concerns with being negatively evaluated, we're going to go with a social anxiety disorder. With this final communication disorder, social pragmatic disorder, The issue involves an ability to discern and then implement those pragmatic changes to language that consider context, that incorporates context. So it represents a difficulty in verbal and nonverbal exchanges in social contexts. There are things that we do when we're speaking to one another. We roll our eyes, we give sighs, um, we say things that we don't really mean in a literal sense. That's what is meant by this social pragmatic deficit. There's a lack of insight into what the normal or even expected rules of conversation might be. That's a part of this disorder. Also, the subtle and the non-literal meanings may be misunderstood. We can see when we get to autism spectrum how that pragmatic understanding can be lost in an autism spectrum if the pragmatic nature of language is coupled with the other symptoms in autism spectrum. We would lean into that disorder. If we have just the component of this pragmatic nature, the subtle, the non-literal meanings are lost. The inability to fit language to context, we're going to go with a social pragmatic disorder only. Now let's switch gears to understand another or to address another grouping of disorders, those intellectual disabilities. There's a significant amount of testing and assessment that's going to go into determining the presence of an intellectual disability. The deficits are based on neurotypical parameters and the significant discrepancy between a person's intellectual capacity and adaptive capacity in comparison to that neurotypical base. An intellectual disability is determined from a clinical interview, but it's confirmed via standardized testing, likely that level C instrument or those level C instruments for which a doctoral degree is going to be required to administer. Okay. Certainly, if you get the necessary training and supervision to do level C assessments, you certainly can, but that's going to be needed to confirm the presence of an intellectual disability. Those deficits are going to come across in processing and planning and problem solving and judgment. Those are going to be the categories that are assessed. These areas are going to be foundational for a person's independence and ability to hold responsibilities for living. Like with the other neurodevelopmental disorders, signs of deficit are going to be noted during those early developmental stages, and intellectual deficiencies are going to be measured as mild, moderate, severe, and profound according to the differential between intellectual and adaptive capacities. In order to have an intellectual disability, all three of these must be met. Okay, just like the others thus far, all of the categories need to be met. It's not one out of or three out of. Next, our focus is going to be on the likely familiar diagnosis of autism spectrum disorders. Before the DSM-5, the diagnostic manual included autism, which represented the more severe end of a spectrum of behavior, and Asperger's, which represented a mild version of autism. In the DSM-5, it was determined that the disorders really represented the same constellation of symptoms versus representing distinct conditions. As such, we now have autism spectrum disorders. Essentially, it's a combination of high and low functioning as it regards the need for support to be independent and responsible. So it's a combination really of those two disorders. Now, what does autism look like in terms of symptoms? It entails deficits that present in the form of social communication and social interacting. To qualify, there must be evidence of three of the three issues. You must see impaired social emotional give and take or reciprocity. There must be deficiency in understanding nonverbal communication. And three, the deficits in developing, maintaining, and understanding relationships and relationship dynamics must be present. Okay, so the person must be able to form relationships, but also understand relationships enough to be able to maintain them. Of the restrictive repetitive behaviors, which we're going to refer to or are referred to as the RRBs, two of the four must be present. There must be an over-reliance or over-dependence on routine. We can see how this could be associated to a OCD kind of behavior. It can kind of mimic that, but it's happening in conjunction with these other things. Okay, so there's the over dependence or over reliance on routine. There is a great sensitivity to changes in the environment or the routine. There's an intense focus on a specific topic, let's say space travel, where the person knows all of the details. It's all they talk about is space travel, or that specific focus on a particular item, trains, phones, cars, those sort of things. And then four, sensory sensitivity, either to touch, to textiles, or stimulation. Two of the four must be present. So you have your RRBs and you have your deficits in social communication and interacting. With autism spectrum conditions, the specifiers make note of whether or not there is intellectual impairment. This means then that autism is not considered to be an intellectual disorder. Sometimes we hear people say, but they understand really well, right? Like they do well in school, the same as people will say with ADHD. It is not an intellectual deficit. Okay, so you will specify whether or not that is also a problem. It's separate. You're gonna specify whether or not there is a language impairment because it's also separate from language development. And again, the neurodevelopmental disorders can co-occur. You would specify if the disorder is associated with a known medical or genetic condition, and then you would specify if autism is present with catatonia. We talked about that before, okay? So the former Asperger title will now be diagnosed as autism spectrum disorder without accompanying intellectual impairment and without accompanying language impairment, and without the need for support with social communication and all of those things, or without the RRBs. So we're not saying Asperger's anymore. We're saying autism spectrum with or without certain things, specifiers. Autism spectrum disorders, we also have severity ratings, which consider context and changes across time. These severity ratings apply to autism spectrum as well as intellectual disabilities. Okay, so I didn't say that with the intellectual disabilities, I clumped it here in a single slide. So these particular severity ratings apply for both, and it represents a need for support and not the severity of the symptoms. So I know the language is a little bit confusing because severity has usually meant in terms of the symptoms, but really here it means the need for support. So when we think of a mild severity, that means it's a level 1 and it's requiring minimal support for the person to be able to carry out their expected activities and to be independent in their living. Okay, it's a level 1 or mild minimal support. A level 2 severity would mean that the person requires moderate or substantial support in carrying out independence. And then a level 3 would suggest severe or requiring very substantial support, not being able to live on their own, versus somebody with a moderate level support. They'll probably live on their own, but they're going to need assistance. And then mild, they are not really going to and be independent and carry out activities without needing somebody to help them with that. I've included about 4 or 5 videos after this slide of children with autism spectrum disorders. At first glance, it might be difficult to notice the behaviors that the specialists are pointing out, but this is because autism sometimes requires a trained eye to be able to distinguish. But you're going to hear the narrator in the final video distinguish between what is neurotypical and then what's going to be neurodivergent. Okay, that's language that we use. Neurotypical, neurodivergent, meaning it's diverging from what we would expect. When you watch the videos, pay attention to the mothers, the caregivers in these slides. Notice their tone of speech and their body language. In some of those cases, there's going to seem to be an impatience with the child, a frustration. I can only imagine how difficult it must be to want to connect with your child, only to have that seem to be met with avoidance and or an ignoring of the attempts. And so you hear that desperation in the tone of the parent. So pay attention to that. I'm going to move past the slides here because as before, they won't play, but you will see these in the PowerPoint slides, but it won't be here. It won't play in these videos. So I'm just going to move past those, but just notice what you notice in the videos, and also notice the high energy that comes in the individuals who work with children with autism spectrum conditions. So now let's turn our attention to attention deficit hyperactivity disorder. Before we do that, I just want to make a note. There is no ADD. We used to have attention deficit disorder, and then we had attention deficit hyperactivity disorder. Now we just have attention deficit disorder, and then there are types. The final disorder here is going to be in the neurodevelopmental disorder category, ADHD. It looks at inattention where you have inattentive type. So you have ADHD inattentive type. It also considers hyperactivity in hyperactive type, or then you have a combined type of both, where there is both attentional deficits as well as hyperactivity. And these interfere with daily living. So it is inattention and hyperactivity that interferes with the person's ability to carry out the usual activities in the manner that's expected. Importantly, the inattentive, hyperactive, or combined behaviors must occur across multiple settings. We've talked about this before, or maybe we haven't, I'm not sure. When we're considering disorders like this that begin in childhood, we want to make sure that we see this in multiple settings. Otherwise, there might be something specific to that setting that we want to consider and look at before we conclude that a disorder is present. Is it present everywhere, or is it just present in specific areas? If so, if it's just specific, we want to examine that and not consider that a disorder is necessarily present. Although ADHD is present in adults, the symptoms must present by 12 years of age. Okay, so if you have an adult that comes in and let's say they haven't been diagnosed or they weren't diagnosed in childhood, that is okay, right? We do see individuals who get into adulthood and they haven't been diagnosed because a parent doesn't believe in it or a parent has managed that in some other way, right? However, the symptoms still must have been present by 12 years old for you to give the diagnosis. They have to evidence that those things were happening in childhood before an adult diagnosis can be given. Now, the symptoms of inattention include things like a lack of focus on detail, difficulty sustaining attention, not seeming to listen when spoken to. There's a lack of follow-through on completing tasks. Organizing is problematic. The person may be forgetful. They lose things. They also avoid activities where sustained attention is going to be required. Now, this one is sort of a stickler because you could have children who could spend hours on video games, right? And that looks like they don't have an attentional issue. But those things that require that they focus or may have difficulty focusing on because of reading, for example, and not only needing to read, but to understand and comprehend and those sort of things, they may struggle with, not because they have a learning disability for reading or written expression, but because it requires this all-in focus different from what may come naturally in other areas. Okay, so that lack of attention to or ability to focus for extended periods, it doesn't mean that they can't focus on anything. It just may mean that they avoid activities where a sustained attention and focus to then produce something from that is needed. The hyperactive and impulsive symptoms are listed here to include the classic fidgetiness, the excessive talking, the display of energy, or that excessive display of energy. The person interrupts, they speak before their thoughts are well constructed. Um, they have a difficult time waiting to be called on, taking their turn, right? So they're not raising their hands, they're interrupting. That is what is meant by the hyperactive and the impulsive. They're acting before thinking, perhaps. There's an acronym that could be used for screening an adult with ADHD. Let's say the person wasn't diagnosed in childhood, but the symptoms are present or should be. You're looking for things like what I put here in the acronym of fiscal drop. So not being able to complete tasks is present. The person may be irritable or sidetracked. They may be careless, not really paying attention to detail, absent-minded. They're a poor listener, right? The person is also easily distracted. They don't like to read, or they say, I'm a bad reader, because they can't focus on the details. They get lost in the words of the pages. They lack organizational skills. They tend to be procrastinators, right? So those may be some of the ways that they describe themselves differently than the not raising their hand, not waiting their turn. They may also do those things, interrupt people in conversation, but they may describe the symptoms differently than we may notice in a child, right? There may also be fidgetiness, but it doesn't present the same in adulthood. Now, the following slides, I will let you go through on your own, but it talks about the accommodating and the understanding of neurodevelopmental disorders and their impact on families and children. So make sure that you go through these for full understanding on your own, but I won't necessarily go through them here. In this particular slide, I'm talking about federal guidelines, the Free and Appropriate Public Education of 1975. Make sure that you review this so that you can help parents understand, or individuals understand, what their rights are should they have a neurodevelopmental disorder that qualifies. Then these are the rights that are presented by the federal government. In this particular slide, I'm talking about the social impacts, the difficulties that individuals have with peers, the social isolation, the impact that might be present parent to child, sibling related, when there's the presence of a neurodevelopmental condition. We would like to believe that children engage uh, with more patience. That's not always the case. And so this slide speaks to that. The intrapersonal impacts that a child may feel when they have these deficits, the anger that they have, the denial that they may present with, the negative perception that they may have of themselves because of their inability to interpret social cues and language appropriately. Of course, as I mentioned in viewing the slides, there are impacts on parenting. The parent's ability to participate and engage with their child is going to cause impacts or have negative impacts on the relationship, the disappointment, sometimes the denial that leads to delay in the diagnosing, which just allows that issue to fester. Probably in the background you can hear the birds. Um, I'm creating this video with the birds sort of chirping in the background, so I apologize for that. But the relatability impact is going to be there when a parent has a child that they can't communicate well with. And then I've talked about here the impact on the family environment generally. Sometimes there is that good child, bad child, the child that takes the focus away from the rest of the family. Because this child can't do these things, the rest of us aren't able to do them either. Okay? The defensiveness that may happen between siblings, either defending or wanting to push away from a sibling with a developmental issue because of shame. There, that issue is present, and we need to be aware of that in our um, diagnosing and treatment. Less in the diagnosing, but more in the treatment, things to be aware of. And then on this final slide, I just speak to the dynamics that might happen in a school environment. Not only do individuals with neurodevelopmental disorders have impacts at home, they certainly are going to have impacts with teachers. Much of a child's day is spent at school. So we can imagine those impacts when they aren't able to get along well with peers or the teacher reacts negatively. We know that teachers don't always respond well, for example, to children who disrupt the learning environment. That can happen with an attention deficit disorder. Let me just go back there and just end by saying that when we think about attention deficit hyperactivity disorder, inattentive type is going to be diagnosed more often for girls than for boys. Boys tend to present more, not that it can't be the case that boys have an inattentive type, but boys tend to be diagnosed and to have the hyperactive, impulsive type more often than they will be diagnosed with inattentive type. But children with ADHD inattentive type may go undiagnosed longer. These are individuals that are more quiet. They're getting lost in their thoughts. Their thoughts are wandering such that when they come back to the present moment, they realize they've lost information because they've been daydreaming. Nobody knows they're lost in their thoughts because they're just sitting there and those things can't be seen, right? So, an inattentive type may go undiagnosed for a while, which means the suffering for that child is allowed to linger simply because it's not being noticed. And the child hasn't mentioned, I get lost, but it may show up in their educational performance. And again, not because they don't understand how to do the work, but because it's not been recognized that they aren't paying attention to know how to do the work. And so we have these issues with, being disruptive or lazy or not smart when in fact something else may be the case. So I hope that you have a better understanding of these particular issues. I like to extend that if a person is going to practice in this area, that you get additional and specific training and support and supervision with somebody who engages neurodevelopmental issues regularly. This is not something you just jump into. This is something that you get additional training because you need those developmental parameters to help you understand when and how to observe and notice these disorders and then to test for them. Okay, that will do it for Module 1. There is a Module 2, so look for that as well.